Okay. Good afternoon. Welcome, everyone. I'm Brenna Metzler with Let's Grow Kids, and LGK is pleased to facilitate these conversations where you, Vermont's early childhood educators and Vermont's leading health professionals, can meet to discuss the well-being of Vermont's youngest citizens. As always, this will be recorded, and the recording will be posted on LGK's website. The nurses and doctors will address the questions that you submitted when you registered. And if you have other questions, please drop them in the chat box. We'll get to them later this hour. Katie and Molly will get us started. So I hand it over to you. Thank you.
Hello, everybody. Thank you for everyone for joining us today. We know your days are extremely busy, and we really appreciate you guys all taking the time out of your day to join us. We know there are a lot of questions about what to do at the end of the public health emergency. We're going to do our best to answer those questions and some of the other pre-submitted questions. We are joined today by Dr. Brina Holmes, Dr. Becca Bell, and Lindsay Johnson. Lindsay is a dual certified newborn care specialist and a child passenger safety certification instructor. So we're going to start off today with Lindsay sharing about Vermont's car seat safety program, and we'll have a brief refresher on ticks, and then we're going to get into information on COVID and the pre-submitted questions. So Lindsay, you want to take it over?
Sure. Yeah, this is great. I'm glad. I didn't even know that this was happening, so I'm really glad that it was here. I'm glad that I was with Sid when he said he wasn't available to be here. So as was stated, I am a certified newborn care specialist in the state. I'm a technician certification instructor for our car seat tech program. And I'm also the child passenger safety specialist at Waterbury Ambulance. So I do a lot of the first response and EMS pediatric calls and making sure that everyone is as safe as possible. And our program is really important just because every 5 seconds a motor vehicle crash is reported to law enforcement, and every 14 minutes one of those crashes becomes fatal. And it's super important because vehicle safety systems such as our seatbelts and airbags are only designed to protect adults, right? So what do we do if somebody is smaller than an adult, i.e. a small child? We have to basically retrofit vehicles, right? And that's where we get car seats, because we want to make sure that kids are safe in cars, and our car seats can reduce the risk of injury and fatalities by up to 75%. So it's a big number. They make a huge difference, and we really want to convince people to use their car seats and use them well. Over half of caregivers all over the country, so nationwide, over half of caregivers make at least one mistake when they're installing their car seat or harnessing their kid in their car seat. And car seats can't do their job unless we're using them 100% correct 100% of the time. So it leaves a lot of gray area. So part of our job is to make sure that we take out those variables and make sure that kids are as safe as possible. There are over 300 models of car seats, so we never expect anyone to know everything. Even as a team, even within our program, we have to reach out to each other. So we never go about thinking that anyone's harming their child on purpose. They're not using their car seat wrong. They just don't know better. So education is a huge piece of what we do. So specifically for our program, it's called Be Seat Smart, and it is part of the Department of Health. We work under the Injury Prevention Department, and we're all volunteers. We're certified by Safe Kids Worldwide, and we are here to educate caregivers on proper selection, installation, and use of their car seats. But the best part of what we do is that we walk through their individual situations. So it's really hands-on. We take their vehicle, we talk to them specifically, we work with their child and their specific car seat. So I'm sure you've seen there's so much information online, mommy groups, friends talking to friends, but that doesn't really put the whole situation together. We do a lot of puzzle piecing to make sure that everyone fits and everyone is as safe as possible. And we're not an installation service. That's a huge piece where we get calls all the time saying, hey, I need you to put my car seat in my car. Or people drive through our events and they say, I'm here to get my car seat installed. That's not what we do. We make everyone do the work. We give them the hands-on piece of it. And so that when they leave, they're able to use their car seats correctly for the remainder of the time that they're using that seat. So it's really huge. It's really fun though. We like what we do. We like working with people. We like educating them. So we do have a website, and that is beseatsmart.org, and you can find all sorts of information. We have information just on car seats in general. We have links if you want to sign up and become a technician. We do have classes coming up in June and August. They're both up central northern Vermont. So we have a Grand Isle class. We also have a class in the like Barrie Montpelier line. So we do try to do classes all over the state to incorporate everybody. And then you can also find our fitting stations. They're all listed by county. So you can find one that's close to you, give them a call, set up an appointment. Like I said, we're all volunteers, so not everyone is available at the drop of a hat. That's hard to get across to people. So if you are mentioning, you have clients coming into your daycare centers and whatnot, it might not be tomorrow that you can get your seat checked, but we really will try to get them in. On top of having our fitting stations, we also offer public car seat check events, which you'll see advertised throughout the state. And those are drive-through, first come, first serve. You still get the same exact attention that you would get, so to speak, if you were coming to a fitting station. It just means that you don't have to nail down an appointment. You'll simply see the signs or see that there's an event, come anytime within the hours that the event is happening, and there'll be lots of text there, and they can walk you through what you need to do. Everything is free, which is a great part of our program. Nobody should be charging for car seat checks or for car seat checks. So if that is happening, bring it to one of our attention, either to me or to Sid or someone within the Department of Health. If you're like, mine wasn't free, because that's a huge no-no. We also offer a free seat program for low-income Vermonters. So any place that has a fitting station, you can call any number. And if you have someone who can't afford a new car seat, we'd rather them get one through our program than have a used car seat, which could potentially be unsafe. Car seat they found on the side of the road, could be crashed, it could be broken, it might have missing parts, and therefore it's not going to work correctly in a crash. And we have a few things that would qualify them. So if they call, anyone that they call who's a certified tech will know how to walk them through to make sure that they qualify. It's a pretty simple process. There's no paperwork or anything like that. The only caveat is that they don't just come in, get a seat, and they get to leave. This isn't just like handing out free car seats for them to do whatever they want with. They need to bring the child if possible and bring a vehicle. And they do have to go through the whole process of having the inspection so that we can give them proper education on how to use the car seat. And then with that program, I like to literally put a piece of tape on the car seat with the child's name so that it stays with them. So these car seats aren't just bouncing around or getting into the wrong hands. But we have plenty. We love to give them out. We want to keep everybody safe. So we're pretty lenient with our program. I'll go over a couple general rules of car seats just for you guys, because you see them coming in or you have field trips, see kids using them, that sort of stuff. Car seats really shouldn't move more than an inch side to side or front to back at the belt path, which is where they're buckled into the car. So you'll be able to tell pretty easily if they're way too loose in the vehicle. We want them to be nice and tight. If you're using a forward-facing car seat, all car seats will have what we call a top tether. That top tether is super important, and make sure that it's used. It cuts forward movement for about 4 to 6 inches, which is about 4 to 6 inches less that your spinal cord will be stretching in a crash. So it's a very, very important piece that often gets overlooked. Harnesses need to be tight enough to pass a pinch test. And we always do a pinch test up at the shoulder where the harness comes out of the car seat. And if you can't pinch any webbing, then the car seat is tight enough. If you can pinch any slack, tighten it down. Obviously, we don't want to be tightening it to the point that we're cutting into children or they're screaming that they're uncomfortable. So you can always do a reverse pinch test where if you hold the slack and tighten at the same time, as soon as it slips from your fingers, then you know that the car seat's tight enough. To make sure that harnesses are nice and tight, we don't want any bulky clothing under them. So as light layers as possible. It gets really cold here, or we just had like a hailing downpour yesterday. So blankets, jackets backwards, things like that are definitely okay as long as they're going over a properly tightened harness, right? We want kids to be warm, but we also want them to be safe. So, no down jackets, no full snow suits, not even just snow pants, because then you're talking too much bulk around the hips. And this goes for kids and boosters as well, and actually us for adults in our seatbelts. We want light layers. We want those as close to our body as possible. So even if a kid's in a booster, not necessarily using a harness, we still don't want big bulky jackets. And another big thing is to never modify a car seat. So what you get from the manufacturer in the box is all you get. That's what's been crash tested. That's what we know is safe. We don't ever want to add accessories, toys dangling. We don't want to add extra padding that stops the child from moving. Everyone loves to put extra stuff around like a newborn's head, right? They're very floppy. They like to kind of sleep all funny. We actually do not want their heads to be so secured that they can't move at all. It's going to negate all of the physics when we get into a crash. So no extra padding. I know it's cute. It comes in different colors, fun animals, things like that, but you really have to use only what comes in your car seat. So best practice for car seats, we are really, really pushing extended rear facing. We want kids rear facing in their car seats as long as possible. What we're trying to do is protect their head, neck, and spine, right? Kids are very different on the inside than we are. They're born with about 300 bones. So there's a lot of things there that haven't quite fused together, and we really need to keep them safe. So rear facing as long as possible. Long legs are never a reason to move them forward. Those legs can touch the seat. Those legs can touch the ceiling. Those legs can sit behind their head if that's how they're comfortable. But we're really protecting the head, neck, and spine. We never want to rush car seats. I know it's hard. You have a 10-year-old who's really little and could still fit in their harness. We want to see that 10-year-old in a car seat in their harness. And we really just want to keep them as safe as possible because every car seat will have a minimum and a maximum for height and weight requirements. We want to max them out. We really, really want to max them out. And it's an either or situation. So if they reach the weight limit and not the height limit, you still have to go to the next level, or vice versa if they hit height, but they're not at the weight limit. So it's one or the other. Every seat has an instruction manual. They have stickers on them. They'll tell you exactly, give you your limits. But as far as rear facing goes, we're seeing seats up to about 40 pounds, 40 to 50 pounds, and like 40 to 49 inches rear facing. So you could even have 6-year-olds still rear facing. They're so much safer. And most children, we find actually, I think it's 46% of children between 10 and 12 actually should still be in a booster seat. So a lot of people think at like 8 years old, let's ditch the booster. But what happens is then the seatbelt still doesn't fit them properly because they're not big enough. And if the seatbelt doesn't fit, then the seatbelt is a moot point, right? We talked about how seatbelts are meant to fit adults. An 8-year-old is not the size of an adult. And believe me, they don't have the maturity of an adult either to sit properly, keep that seatbelt on, not fall asleep on the window, not, throw the shoulder strap behind them. So booster seats, we really want to push booster seats as long as possible. And then the final step of child passenger safety is to make sure that all kids under the age of 13 are staying in the back seat. Those airbags even have a warning on them in a vehicle that say that they can be fatal, right? Not just an injury, but a fatality. If a child is not big enough and not mature enough to be sitting in the front seat and wearing a seatbelt, and the airbag is not going to help them. Instead, it's going to do the opposite. So 13, back seat. For you guys specifically, we went through as, childcare providers and how you can really help us. And one of the things we really want to push is that it is not safe to sleep in car seats outside of the car. Infant buckets are not meant to be used outside of the car, right? They're very convenient, but they're not a place to sleep. They're not a place to hang out. They're not a baby holder. They're not a nanny, and they're not a crib. What happens is they're not at a correct recline angle and babies can fall asleep, get into a state of positional asphyxiation, they stop breathing, and they can pass. And it's very scary, but it's very real, and it happens every single year. So specifically, daycare should set policies that either do not allow their infant seats to come into the building, or the infant seat comes in. You as providers do not touch them. The caretakers take their child out. The seats go somewhere other than the classroom. And then they're only touched by the provider or their caregivers when they come back in, and the caregivers are the ones to strap them in and take them out. So they should never be placed into a sleeping space. They should not be put in their car seats during the day at daycare. And you should warn parents that they shouldn't be sleeping in them in general. Choking in car seats is a huge thing, right? Car seats get so gross and they're so hard to wash. So hard, and you have to follow manufacturer's instructions. So across the board, we say no eating in car seats. It takes a long time to safely pull over a vehicle, unbuckle a child, take them out of the vehicle, and pull whatever it is out of their mouth. So if you just nix it from the beginning and say that car seats aren't a place to eat, then we're getting rid of a whole issue. We actually get that question a lot from providers. They ask if we have any materials or whatnot. We don't as of now, but you can spread your wealth of knowledge. Somebody came in. This is a real example, and it just happened a few weeks ago. It was a daycare provider, and they were concerned because a baby came in sleeping in their bucket with a piece of bread in their mouth. So just so many things. So spread the education, let them know that it's just not safe to be eating in car seats. So vehicular heat stroke prevention is a big thing you guys can help us with too, is not leaving babies in hot cars. Nobody ever does it on purpose, but it could just be a change of schedule, a brand new care provider. For the last 5 years, they've been driving to work and they haven't had to stop. And this is the first day ever that they've had to drop a kid at daycare, and their brain just, whoop, right? We forget to get gas on the way home. We forget to stop and get milk until we get home, and we just go, ugh, right? Don't do it on purpose. It's the psychology of it. It's brand new. So if you guys have a child that is supposed to be in your care and they did not show up, check on them, call the parent, make sure that baby is not stuck in a car while mom and dad or the other caregiver is at the office and completely forgot. You can really help prevent some tragedy there, as well as if you guys are taking them out for field trips, things like that. Any kid, make a list, make sure you're counting as they get out of the vehicle, make sure you're counting as they get back into the building, right? If anyone's missing, check the vehicles, make sure nobody's left behind. Safe Kids offers whale kits, and a whale stands for we had a little emergency. And it's almost, you guys all know Baby on Board, right? You've seen the Baby on Board stickers. So what this program is it's along the same lines where there's an indicator sticker that there's kids in the car. There'll also be an indicator sticker on the car seat. And what that'll do is it will send first responders to the glove box where there will be more information in case you have children who either are illiterate or not speaking. You also have tiny babies that just can't speak for themselves. And if you're ever in a crash and parents are unconscious or they just don't know if it's a different caretaker, it'll have all of their information listed. It's a little safer than stickers we used to have that put all the information right on the car seat. You don't really want people stealing all of your information off the side of a car seat, but we are trying to train all of our first responders to look for those whale kits so they can go to the glove box. They have all the emergency information that they need in the case of a crash. And then the last thing before you guys ask any questions is we always get asked, what is the best car seat? What is the safest car seat out there? And the safest car seat, very simply, is one that fits your car, fits your child, and that you as the caretaker can use 100% correct 100% of the time. Cost doesn't make a difference on safety of a car seat. A car seat that's $60 or a car seat that's $1,000 passes the same crash test safety standards. What you're paying for is really good marketing, extra things and things that we call ease of use. So zip off covers that are easy to clean, extra cup holders if you have a kid that, needs to have milk, juice, and water all at the same time. Things like load legs, side impact, crash testing. Those are not anything that we have legally given any testing to. So you're paying for fluff, you're paying for good manufacturers. So if anyone says, well, I can't afford that super nice seat, your kid's going to be just as safe in the cheapest seat that you can buy. So safest and best car seat is one that fits the kid, fits the car, fits your lifestyle, which means that you're using it 100% correct 100% of the time. I think that's it for our general overview. It's a lot. Any of us in this program could talk for hours and hours on car seats. It is a 35-hour course. So there's so much that goes into it. And I can leave, all of Sid's information and everything in the chat if everyone would like it. But does anyone have any questions, comments, concerns?
If you have questions for Lindsay, just pop them in the chat and we'll get to them as they come in. But it is a great website. And fun fact, I was a certified car seat tech in the state of Vermont for 10 years. Woot woot, all good information. Thank you, Lindsay, for sharing that with all that information and that website with this group of educators. So back to you, and I will go off screen again.
Thank you so much, Lindsay. Let's just see. I don't see any questions right now, but I'll start on the next section and then we'll get into the Q&A. So if anything comes in, please just, again, put it in the chat. But we just wanted to take a second to talk about ticks. We did get a pre-submitted question asking about if there was any new information regarding ticks and what to do if one is found on a child in care. So we checked in with some of our colleagues at CDD, and they said that they would just recommend following VDH instructions as far as if there is a tick on a child. So I just wanted to do a quick reminder of kind of what our process is with ticks. We have the general health guidance is protect, check, remove, and watch. So protect, this is saying we want to avoid areas where ticks are found. They're generally in wooded, brushy areas with high grass. Want to use an EPA registered insect repellent, and wearing pants, long sleeves, and long socks can help protect you as well. Obviously in the summer, that's not always as feasible, but wearing light colored clothing can help you spot ticks more easily. And we can see ticks year round, but we really are going to see them most active in the spring and fall. So just being aware of that, those extra high areas. Next is checking. So checking clothing, gear, and pets before going inside. For all of you, it's going to be really important to monitor the kids as if you have outside time when you're going in, doing a tick check when you go in. I know it takes me a while to check myself. So making sure that you're helping kids who aren't going to be able to necessarily notice it or think it's just an ant and, a fun bug, like you don't always know what the kids are thinking. So you got to make sure that we're checking them as they go. And then for removing ticks, I am going to give the description of what it says to do for removing ticks, but I'll also just let you know that on the VDH website, which I'll put in the chat after, there is a video to help kind of clearly visualize what I'm going to say, because I know I learn much better seeing it versus hearing it. But if you do see a tick, you're going to use fine tip tweezers or a tick removal tool, and you're going to use a steady motion and just pull straight up until all the parts of the tick are removed. You want to dispose of a tick by putting it in alcohol or placing it in a sealed bag or container, wrapping it tightly in tape, or flushing it down the toilet. You never want to just crush it with your fingers. And then afterwards, you're going to clean your hands in the bite area with rubbing alcohol or soap and water. And then the last part is watching for symptoms of tick-borne illness for 30 days after the tick bite. So symptoms could include fever, chills, rash, headache, joint pain, muscle aches, or fatigue. So if you notice any of those symptoms, you're going to want to contact your healthcare provider, let them know that you had a recent tick bite, when the bite was, what kind of outdoor activities you're doing, just so that they have that whole cool picture. And so letting families know if there was a tick on their child to just be monitoring for those as well. And the other thing is, again, this can be a lot to remember all at once. So just knowing that if you have any questions about ticks or you need some educational materials, you can always reach out to your Office of Local Health for support as well.
Thanks, Molly. Yeah, the Office of Local Health has nice little pamphlets you can give to parents that show the ticks and all sorts of good stuff. And I don't know if the pediatricians have anything further to add about ticks or anything they feel like before we move into the Q&A. Okay. So as you all know, the public health emergency is scheduled to end on May 11th. And what a very wild 3 years it's been. We know that ending the emergency can bring up a lot of questions and concerns for you and parents and the families you work with. So we want to reassure you that we're be here with you every step of the way as far as answering questions and if things come up. And if you're looking for any kind of like silver lining from COVID, for us, it would be that the health department, we're so thankful that we've been able to strengthen our ties to all of you throughout the pandemic. So we talked to our EPI team, and currently there are no planned changes to Vermont's COVID-19 recommendations when the emergency ends. So if this information changes, we'll do our best to notify you, get that word out of any changes that might come. And with that said, we did get some questions on COVID, so we're gonna jump right in and answer those.
So the first question was, with the COVID-19 emergency ending, what are the plans for COVID-19 testing? Are you recommending testing only when symptoms are present? So as of right now, we have not heard about any changes to recommendations around testing when the emergency public health emergency ends. But the current recommendation for testing is only when symptoms are present. So we do not anticipate that changing as of now. I don't know if Becca or Brina has anything else they would want to add to that.
Yeah, hi everyone. I was just going to weigh in, having seen these questions ahead of time, that I just really wanted to observe and sit with you that you're still really in it. And I think sometimes in our efforts around COVID, there's a whole group of people who have moved on, and then there's a whole group of people that are still really day to day experiencing the impacts of childhood illness. So in that spirit, I just wanted to remind you that your pediatric colleagues and community really want to help you with this. And I am trying to find the silver linings, or the sort of what are we going to take away from these 3 years? And for me, it's these partnerships in this sort of shared effort to improve our community health, but also support each other in the care of children. So if there's any way, Becca and I are really committed to these partnerships. We know that you have medical colleagues in your community that are hard to communicate with and maybe doing things that are not in support of your field. But I think the vast majority of people who deliver healthcare for kids are actually aware much more now of how hard it is to care for kids in settings like yours. And so the testing question just brought all that up for me, which is, you really don't have to be in that space anymore. And what you could really advise in a perfect setting would be for families to talk it over with their medical home and decide when they need a test, which is really different than the role you had to play for those 3 years, 2 years, 2.5. Whatever timeline you want to put on this, you were really deeply in the medical advice business and having to establish protocols. And I think we're back to childhood illness being a big pain in the neck, some of which is COVID, most of which is not. And how we can help you with the medical partnerships is the ongoing commitment and effort.
Thank you, Rena. That was lovely. So moving on to the next question. So is a COVID-19 vaccine for small children still available? One of our parents said the pediatrician told her it was no longer available. So yes, the COVID-19 vaccine for small children is available, and information can still be found on our COVID-19 vaccine webpage. Molly's going to drop that in the chat if she hasn't already. If this question comes, or this concern comes up again and you're comfortable, please feel free to reach out to us and let us know about situations where this might be happening, so we can provide outreach and support to the healthcare providers to ensure that everyone has access to the vaccine, so we can clarify if there's any confusion around the vaccines are still available, and or help support the access there.
The next question was, can we obtain COVID tests for our families, and how do we advocate for this? So we have brought this up with leadership a few times. We have not heard about any updates about restarting the distribution of tests to childcares. On the COVID-19 testing webpage, which I'll put in the chat after, there are recommendations for how to obtain tests, including ordering free tests through the federal government or checking with your Office of Local Health. As far as advocacy, if you guys want to, we want to encourage you to continue to reach out to us with any of these concerns, requests, and we're more than happy to pass along this information.
Okay, we have one last question here. So what is the latest guidance when someone tests positive for COVID? The Department of Health website no longer mentions a day 0 or masking for an extra 5 days after isolating for 5 days. So I'll just go over this again. And then also, knowing that this information is on our website too, if you need to reference it, if just going over it verbally is not enough. So if you test positive for COVID-19, isolate as soon as you receive your test result. So even if you're vaccinated or never have symptoms. Isolation means staying home and away from other people for at least 5 days from the date of your positive test or the start of your symptoms, whichever is earlier. So although there's not an explicit statement around day 0, the guidance remains the same for how we would count the isolation days. So starting with the date of the positive test or the onset of symptoms, whichever is earlier, and that's for the isolation period of 5 days. And then you can end isolation after 5 days if your symptoms have improved and you have had no fever for at least 24 hours without the use of medicine that reduces fevers. So masking for an extra 5 days after isolation is not a current recommendation from the Department of Health. So with that said, we have time left on our hour here for questions. You've got car seat specialists as well as 2 pediatricians. So feel free to put questions in the chat or speak up if you have thoughts.
And we did have
I
one.
might- Got it.
I was just going to say, Katie, I might just talk just generally about respiratory illness. So I work in the ICU, and so my perspective is a bit different than, the great knowledge from the pediatric primary care providers. But I just want to reflect again, I did this, I think, last time on the season that we just had, which was a really tough respiratory season for kids. And so if you remember the fall and winter being terrible, it's because it was. And we have now that we're through it, we've been collecting and looking back at our data, and we had the busiest pediatric respiratory viral season that we've ever had. So I think just sitting with that and recognizing that we just went through this really tough season, I suspect, and I think most people suspect, that it won't be as busy in the future, but it will still be busy. We're going to have busy RSV seasons every year until we maybe get a maternal vaccine in the next couple of years. So I think what has been so hard about caring for kids of this age, the kids that you care for, that I care for, is that we went through 3 years of very intense monitoring of symptoms, right? And we're telling families to stay home for the sniffles, and that was a challenging relationship sometimes to manage. And then we everybody got sick. Everyone got so sick this fall and winter. Everyone got 6 viruses, and they were really sick and getting hospitalized. And so it just felt I think demoralizing, for caregivers and for families, because they would come in and say we did all this stuff, we isolated and quarantined and did everything, and now my kid's in the ICU with RSV, what? And so part of this is there was a true viral epidemiologic payback that needed to happen, and it was really hard. So I just want to reflect on that. I don't know. The next question people ask me is when are we going to see RSV? Is it going to go back to being kind of December through April? Is it going to be early again? I don't know, but this is why we have these meetings, so that once we start seeing it or getting a sense of what's happening in other parts of the US, we will definitely let you all know, just in terms of prediction. And then we can kind of talk more about respiratory virus precautions. But we still are seeing a little bit of stuff. We see rhinovirus all year, so we see some of that. But anyway, I just wanted to thank you all for this past few months. It's really been tough, and the data, the objective data backs that up, that we just had the worst season. And it was specifically kids under, it's the 0 to 4-year-olds. So it's you were in it. So thank you for your support during that. So I just wanted to make sure I said that before the meeting was over.
Yeah, so good. Becca, I did notice, some of I have taken on quite a role in the pandemic about chat monitoring? Some people look at chat, some don't. Molly, did you see Sherry Hill's question? That should children be excluded if a family member has COVID?
Yeah, so Department of Health doesn't currently have any recommendations for quarantining. So close contacts don't need to quarantine. They can still go about their day. The key with this would be, as long as the kid doesn't have symptoms. If they have a family member who has COVID and they are also having symptoms, that's when you would want to test them and, use your sickness policy to say, are they well enough to be in school? But if the child is symptom free and they have a family member with COVID, based on Department of Health recommendations, they would not need to be excluded.
So that leads to a question that I think came only to me, and it's around conversations with families when a child has symptoms and the childcare program or the early childhood educator says, hey, could you have your kid tested? And what is your best guidance for supporting families and for making sure that the other children are not exposed to something that might be COVID?
Yeah, I was going to just jump in here on the armchair psychology philosophy thing here. So this is really hard for all of you that have been in the childcare field as long as I've been a pediatrician, which is like 28 years. We've really never gotten illness policy quite right in the care of children, right? Oh, and look, Becca Bell has a real life human on her screen.
So guess who got a fever today, gets sent home from school, but he wants to say hi to Julie. Sorry to interrupt.
Oh, hi, Julie. Okay, that is as if we need more examples of how all
Sick day. Yeah.
Vermont is all local and all relationships. So what I was starting to say, so you've heard me talk about this, our societal issues around the care of children and also school age kids as well, that we don't have any capacity in our employment system, that when people's kids aren't feeling well, they stay home. And then during the pandemic, we just had to put the iron gate down, right? It became all of that wiggle that you've been doing your whole career is about like, no, geez, okay, I totally get the stress on families and that's my top priority, but this doesn't feel exactly right. Like, all the stuff that went on with respiratory illness in particular, we lowered our threshold for the care of children. So the art now of 2023 is, where are you going now? Are you going all the way back to where we were before COVID, where it was a lot of pressure on you to have kids who were not feeling well? No, I mean, I think we really have to be infectious disease and spread of disease experts. I also think you've taught us a lot as people that integrate with your field about what it means to be well at home and what that looks like in a group setting when you show up in a toddler room and a child cannot fully participate, which puts an enormous burden on your ratios on the adults that care for kids. So in that space, I just really feel that we have to partner with families and the medical homes to understand what's going on with kids. If a parent is sent, if you say, please get this kid tested, and they choose not to, or don't communicate with you whether that occurred or not, I can't really answer you on what to do next, except to say that sounds deeply relational, which is I'm feeling confused by this whole scenario, and I'd like to try to understand better why the family, did they not have access to a test? Was the cost prohibitive? Did they actively choose not to test? And in that space, there's no answer. We certainly don't, to the degree we did 2 years ago, say that every runny nose needs a test. And I think we're feeling like the style piece of this is creating some ongoing conflict between families, childcare providers, and medical homes, because all three of those entities are coming in a little different on how to handle this. So in that space, I just really wanted to support you that you don't have to be the gatekeeper for this and tell families they need tests, tell families they need different policies than we've described this afternoon about where we find ourselves in the unraveling of the rule, that there's no longer much going on in the recommendation space, with the exception of the positive test, stay home. Other than that, it's respiratory, it's childhood illness prevention. So I just want to really talk straight with you, and you to talk straight with us about, like, you really shouldn't have testing policies for COVID when they don't exist elsewhere. And excluding kids from childcare, it should be entirely based on their illness and your policies around their child's ability to function in your care, not COVID protocols. I'm not sure if that's helpful. I just know it's still very difficult for all of us.
Brina, I think that was so well said. Thank you. And I was just reading what Julie put in the chat. And I think these conversations during COVID and for the last few months with you folks have been so powerful and so important. And Julie's comments in the chat really remind me that we're talking about the health of children, and we're talking about the lack of investment in childcare in our state. And we have an opportunity right now, as you all know, every one of us at Let's Grow Kids has visited you all through all sorts of ways to ask you to support the bill S56, and investment in childcare will help us have fully staffed programs, which then will help with all the things that Julie talks about in her chat message and what Brina talks about in her relationship between program and parents. And it really is, the work that you all do is a relationship between families and program. And when we fully invest in it, all these things will fit into place. So I don't want to take up any time during this, except to say the value of these conversations with you medical professionals and the early childhood professionals is so important. And I really appreciate all of you.
I think I might just add about thinking about, to add to Julie's, about staying home when sick and like what exactly that should mean, because during the thick of the early pandemic, all of the respiratory viruses went away. And so it was kind of a thing that we could truly not go to work with any symptoms, right? Because we barely got sick. Everyone barely got sick. And then we even saw if you even just think about the different COVID strains, you had less infectious strains early on. It was more reasonable to do this sort of like isolation. We could keep COVID sort of out of places, and then Delta made it really hard, and then Omicron made it impossible. And I remember Brina and I meeting with school nurses. I remember one of the school nurses saying, I feel like I'm trying to like keep out air from the school. Like it was just like, you just couldn't do it. And so I think at that point, we had, it's a less severe strain. We had hybrid immunity, we had vaccines or whatever. And so we had to start thinking about COVID differently. And really a lot of it is to go back and think about this is never going to be, this is the age group that kids, like the point of, of everything is that they get all these colds. I mean, it's so hard. So we're not going to be able to prevent it all. And we know that if kids don't get it, when they're 1 and 2 and 3, they're going to get it when they're 4 or 5 and 6 and 7. It's just a really tough age in terms of illnesses. But going back to just infectivity, it's those first few days, like when you've got a fever, when the kid's really not feeling well, a kid or staff member, that also, one, it correlates to like not being able to work well and not being able to attend childcare, but it also correlates with infectivity. So once you get to the point where you've got you have like this lingering cough, but you like don't have the muscle aches, you don't have the fever, you're feeling well, like you could work, or well, like you could attend childcare, you're also less infectious. And so when we're just thinking about trying to I think I showed you that graph of like when they these studies and they swabbed kids' noses, and like adults that live with young kids every week, and it's just like they all have viruses. So it's like we got to think about, okay, if there's going to be a pattern of like you're most infectious and you get less infectious and most infectious, like how can we get people to school and work? Like how can we cut out the parts where they're most infectious, but understand that there are going to be like runny noses and congestion and cough, and like we're heading into allergy season, like how to like, right, this is really tough. So I do think matching, you know, matching how well you feel, it's so subjective. But if somebody is saying, I feel like I can go around and do my stuff, I just have this cough. I mean, that's a lot different than someone saying, I have muscle aches, I have chills, I feel terrible, and they really shouldn't be there. So, and I don't know. I think it's very hard to think about as like as a director and trying to like help make guidance for your staff around this is super challenging, because you want people to not work if they're not feeling well, but also you don't want to say like, you have to be out until like you never cough again, because you're just not going to be able to staff well. And of course, all of this, I just like want to like underscore what Luann said, like we need better staffing and more support for staffing. Like absolutely, that's like part of it, but also we have to think about how to support our staff. So I think just even just passing on like that, the fevers and the first few days of symptoms are the most infectious, if that's how you want to just kind of talk to your staff about that. I don't know if that helps.
This is also good. So many important topics we're covering today. I just want to point out that in case folks aren't tracking chat, there was a request for guidance around pink eye, and there was a really great exhaustive response from Brina,
Yeah,
straight
sorry
from
about
Caring for Our
that.
Children. No, it's all good. It's all good. About what the protocols for pink eye are, and so if you didn't read that, do check it out. But I'm wondering if anyone would just like to do like the 2 or 3 sentence synopsis of guidance for pink eye. I just remember when I was a director, it was like wash our hands, wash our hands, wash our hands, wash our hands. Oh, wash your hands. Do we wash our hands?
Yeah, so pink eye, like, first of all, this has happened in many webinars with you all where somebody takes us back to a basic infectious disease questions like pinworm or pink eye, and I feel so relieved just for the briefest moment that we're back in our lane of like, oh yeah, those darn pinworms, head lice. I would love to do a talk on head lice. Pink eye is pretty misunderstood. It's just almost always like a little drop of, it's like having a cold in your eye. So if you're letting, if a kid's feeling well and functioning and has a little nasal congestion, you keep them in. So you don't need to exclude pink eye. There are times when it's bacterial, and then you get a couple of cases. It is at that point that some homes can make decisions that you got to tidy that up and get kids home, and the hand washing didn't work for the spread. So the reason I sent such a complex answer out of Caring for Children is there will be tons of medical providers who say to a family with pink eye, here's some antibiotic drops you have to exclude for 24 hours. So there's that like myth busting. And so you may have kids that are excluded for a day based on medical advice that's maybe a little different than Caring for Our Children, and that's that complexity again. But I also think the flip side occurs more often, which is almost all pink eye in kids clears up the way a cold does. And if it doesn't, there are bacterial sources that need attention. I was happy to hear about shared service, that the Caring for Our Children is available to you all. Because, Molly and I have a dream about health and safety and childcare. We've really committed to you all that we've got to get you places to go for just good old fashioned medical advice. It's entirely our intention, and it would be such a better world because you have so much that goes on every day, all day with these kids' health.
So I don't see any other questions in the chat box, and I'm curious if anyone has a question you've been holding that you'd like to pop in. We have about 10 more minutes together, or if there's anyone from among the medical professionals who would like to speak on something else, maybe head lice.
Now we're getting way out of my lane.
Then I'll just do a quick anecdote while folks are considering their question. I was the director years ago. I was the director of a drop-in center for street kids in another country, and head lice was endemic. And so I started laminating small cards on like, lice busters, I called it, and I taught many people how to check for nits and pick them and put them under tape, and how to remove lice and put them under tape, much like you were describing at the top. I think it was you, Molly, that we do with ticks. So yeah, lice busters, we can do it.
Julie, go ahead. We can unmute Julie and you can ask your car seat question. Let me find you here.
Thank you. Oh, there we go. Thanks. So some of us in the call today are a part of a director's kind of cohort. We meet regularly, and a few weeks ago, or maybe it was even a month or two ago, a car seat question came up among programs about like DCF workers or other transport services that might like come pick up a child, take them somewhere, and then bring them back. And us, the directors or like lead teachers, noticing that children were not being properly buckled. So we're humans, right? So we like did what we could to ensure that the child was safely secured. But in those circumstances, like, I think a lot of us felt confused or conflicted about where our duty kind of ended. And then like the child is now in the hands of the other person, but then who ultimately is held responsible for the child being improperly buckled. And then also like in those kind of state workers circumstances, like who would we notify that these people are like consistently improperly buckling or securing children into, or maybe they're putting a child into an inappropriate car seat for their height and size. If you could speak on that a little bit, that would be really helpful.
Yeah, I love that you brought that up. We want anybody who transports children regularly to be certified so that they know what they're doing. As far as your liability, and if it is someone else driving the child, do not touch that seat. Do not be involved, because if a child is injured or dies, a parent or caregiver is going to come after anyone and everyone that they can, right? That is a horrible, horrible, horrible circumstance. It doesn't get worse than a child dying. So I would take all liability off of you as soon as that child walks out the door. I know it hurts your heart, it hurts my heart, but it's not your problem. And just for your own safety, don't get like caught in the hearsay, I guess. So you could spew as much education as you wanted just speaking to them. But if they do something wrong and come back and say, you told me to do it that way, there's no documentation that said that you didn't, that then holds you responsible as well. What you can do is you can push for everyone to be certified. We try to push. It is extremely hard. We understand it's frustrating. People have to take 3 to 4 days off from work, or their employers have to be willing to pay them for those 3 or 4 days that they're going to class. It's a long class. It's a grueling class. So it's not a quick like 1 hour thing and you're certified. So we get that it's tough. But yeah, if your job is to regularly transport children, you should be doing it correctly. Or at the very least, have a contact, have someone who can help. I do a lot with DCF down in Barrie. So between the Washington County Sheriffs and I, we can kind of piece together seats and times that we can help with large transports to come down and sort of give them overviews, teach them, or at least they can give, height, weight, age of child, and we can suggest a seat to use. But at the end of the day, don't be involved. They're gonna like you have to take you out of that equation if you're not the one driving them. But
Okay.
you could call if it is like if it's regular, like if you have kids where it's like every Tuesday at noon, so and so picks up this many children, and it goes on for years. That's their job. You can call and you can push it and you can say they should be certified. Maybe get some of the supervisors to understand that it's an important thing.
And I would say, please also feel free to reach out to me or Katie and like, let us know. We have contacts at DCF and CDD and all those places. And like Brina said, we're really trying to beef up the VDH, like health and safety support for all of you. So as these comes, I know like we've been your COVID contacts for everything, but like we really are here for whatever. So if that comes up, please let us know. And we are happy to do outreach. You know, the car seat safety program lives in VDH, so we can partner with them to connect with DCF. So just letting us know it happens, and then we can go from there.
We do, and we do have techs who do work in all of these departments. It's just hard that it's not everybody. So it may be bringing awareness to that too, because it could be someone sitting at the desk next to you and you just didn't know. So you could just be like, oh, that would have been really easy to just say like, hey, can you go check that seat? So just really, you know, making it a more well-known program or system.
Julie, do
You
these
can-
tend to
go
be
ahead.
like kids who are doing regular, like the same kids doing regular visits type thing, or are they one-off transports, or are they the transports that they have like parental visitation twice a week and so it's the same? Do you
I
have
think-
a sense?
Well, I mean, for my program, it seems to be more like last minute unplanned, like someone couldn't get here and so they needed
Okay.
to arrange alternate transportation. I do know some other programs though have the regularly scheduled visits, and they had concerns about
Okay.
the person who was transporting the children not properly buckling. So I think it's a combination of all of
Okay.
that.
Yeah,
And
I
we
think
do-
this is the perfect like forum to talk about this, because I think you know, Katie and Molly can get in touch with the right people with the car seat, you know, and like I think this, but so also just thank you for noticing that, because it's something that people miss, and that, you know, if you know, I think it's a really important thing to notice and draw attention to. So thanks.
Well, and Julie, I was going to give similar, I mean, all roads lead to Molly and Katie, in case you haven't noticed, but I had this thought of picturing you witnessing it, and how, first of all, how important that is. But what I would say after this talk with Lindsay, I would say, oh my gosh, I just went to this car seat safety talk, and did you know that, you know, half of all car seats are improperly, because aren't you guys thinking about your own personal experience? I mean, my kids are in their 20s, but we kind of botched this over time, because you're always switching cars, and then you're like,
Mhm.
you know, your grandparents, I can just picture the whole thing is really just about a lack of understanding or knowledge, and not anything beyond that. So it is just that slowing down and saying, oh my gosh, there's so many ways we can do this wrong. Do you guys want some help in up in the game?
And we
I was going to end with just a thought as you were talking, that there's been a theme today, which we always lift, which is this ongoing space we find ourselves in, how to work with families. Not so much in Julie's example, but when you see a family like at the grocery store and the car seats clearly improperly installed, like that's been a Brina situation many times. And I just wanted to remind people that we have brought Touchpoints back to Vermont. Touchpoints is this approach where it actually takes what we call family-facing professionals, all of us that work with children, and it makes a slight but very important shift, that we're really not in service of imparting knowledge to families. What we're really trying to do is have families understand, like observe what's going on with their kids, and having questions and engagement with us around their attachment with their kid and their child's development. So I would love for some of you to find, and I know it's really hard with your schedules, but we're doing a lot of Touchpoints trainings, and it helps to just put a little bit of a different frame on all these hard things that go on in service of families. When you're with someone that's not testing, or when you're with someone that's really not taking their kid out of the car seat when they're asleep, even though we've talked about that in multiple settings, it's that stepping back for a second and wondering why, and not not going in on the like, oh, and I'm speaking personally, you know, in pediatrics, like, come on, do what's right by your kid, except they are, and they're trying. And what Touchpoints teaches us is what is the language around making meaning out of what's happening without any assumptions?
So
Also-
really good.
Yeah.
I'm sorry, didn't mean to cut you off. I think that's a really great way to go out today. We are at time, and there are a couple of things I just wanted to say as we wrap up. First of all, we as early childhood educators do recognize that families are and parents are children's first best advocates. And as much as we know about their kids, because we often spend the bulk of their waking hours with them, we really do, in more than our heads and our words, we in our hearts respect that parents are their child's champion and they're doing the best that they can in this moment. And many times they lean heavily and hard on us for expertise around child development and their child's health and well-being. So we are super, super lucky here in Vermont to have such an open and regular relationship with you at the Department of Health and in the pediatrics. So thanks for being with us today. And I'm so happy that the car seat piece is housed in the Vermont Department of Health. That's where I was going to just bring it right back to. And before we go, would Molly or Katie just be able to drop in the chat where people can contact you? Again, I know you do that pretty much every time, but we're just so happy that that you are so accessible. And thanks everyone for coming today.
Thank you, everybody.
Perfect. Thank you. Well, have a good rest of your day.